If you have been prescribed with a GLP medication, semaglutide, tirzepatide, liraglutide, or you're thinking about it, you probably heard conflicting things about what these things do to your bones. Some people say they are bone protective, others say they cause bone loss. And both groups are citing real studies. So who is right? Both of them? And neither of them? Because the answer depends entirely on you, specifically your underlying metabolic health. I am Dr. Doon Lee. I am a board-certified endocrinologist, and today I am breaking down one of the most nuanced stories in GLP research right now. Why the some classes medication can protect bone in one patient and accelerate bone loss in another. Let's get into it. GLP receptor agonists have exploded in use over the last few years. We're using them for type 2 diabetes, obesity, cardiovascular risk reduction, alcohol, addiction, and the patient population is getting broader and younger. And bone health is a long game. Fractures don't happen overnight. Bone density loss is really completely silent. And by the time someone shows up with a hip fracture or a vertebral compression fracture, years of cumulative loss have already occurred. So this is not a theoretical concern. For the patient I see, especially women in their 50s and 60s who are on these medications for weight loss, bone health has to be part of the conversation from day one. Let's start with what we know about GLP-1s in patients with type 2 diabetes, because this is where the data is most robust and most reassuring. A 2025 meta-analysis published in Acta Diabetologica looked at 25 studies and found that GLP-1 receptor agonists significantly improved bone mineral density at the lumbar spine, the femoral neck, and the total hip compared to controls, despite weight loss occurring, which is very counterintuitive. A separate meta-analysis of 26 randomized control trial in type 2 diabetes patients showed similar findings. On fracture risk, GLP-1s were associated with approximately a 20% reduction in fracture risk in diabetic patients. A 2025 cohort study found significantly lower vertebral compression fracture rates, specifically in diabetic population on these medications. The American Diabetes Association's 2026 standards of care characterize GLP-1s at low doses as likely neutral to beneficial for bone density and fracture risk in diabetes patients. So, for the type 2 diabetic patients, this is actually good news for their skeleton. Now, here's where it gets interesting and where the endocrinology really matters. Type 2 diabetes is not just a blood sugar problem. It causes what we call diabetic osteopathy, a specific pattern of bone disease where bone remodeling becomes uncoupled. You get suppressed bone formation, and in many cases, impaired bone quality that doesn't always show up on a standard DEXA scan. GLP-1 receptors are expressed on osteoblasts, your bone-forming cells. In the diabetic skeleton, GLP-1 medications appear to do several things simultaneously. They modulate rank ligand OPG signaling, which is a key pathway controlling how much bone gets resorbed versus formed. They improve calcium and phosphate metabolism. They reduce chronic low-grade inflammation, which is a major driver of bone resorption. And they improve insulin resistance, which independently helps preserve osteoblast function. The net result? In patients with diabetes on GLP-1s, we see increase in bone formation markers, P1NP, osteocalcin, bone-specific alkaline phosphatase. while bone resorption markers like beta-CTX go down. The metabolic benefits are essentially outweighing the mechanical unloading that comes from losing body weight. That's why these patients can lose significant weight and still show improved bone density. Now, let's talk about the patient who does not have diabetes. They are on GLP-1 receptor agonist for obesity or weight management. This is where the picture changes substantially, and where I think many prescribers are not asking the right questions. A 2026 retrospective study of 255 patients found that among those without diabetes, GLP-1 users experienced significantly greater total hip bone loss compared to controls, about -1% versus -0.6%. And crucially, bone loss correlated directly with the degree of weight reduction. In non-diabetic obesity, GLP-1 medications produce bone loss patterns that look essentially identical to other forms of caloric restriction. It's high turnover bone loss proportional to weight loss, most pronounced at weight-bearing sites, the femur, the tibia, the bones that were doing the work of carrying that body weight. Without underlying metabolic bone disease to correct, the primary driver here is simply mechanical unloading from fat mass reduction. The drug isn't doing something special to the bone, the weight loss itself is. So, for certain populations, the risk is measurably higher. A 2025 study of non-diabetic overweight and obese patients found GLP-1 use associated with increased risk of fracture risk, 3% versus 2.6%, an odds ratio of 1.19, particularly in those with a BMI of 40 or greater and age 68 and older. This is a study I think every patient on GLP-1 should know about. A randomized clinical trial published in JAMA Network, open in 2024, looked at liraglutide alone, which is another GLP-1, exercise alone, the combination, with all groups on a low-calorie diet first. Here's what they found. Liraglutide alone, GLP alone, caused significant bone mineral density loss at the hip compared to exercise alone, even though both groups lost similar amounts of weight, roughly 11 to 14 kilograms. The combination groups, they lost the most weight, around 17 kilograms, and yet showed no significant difference in the bone density compared to placebo. Let me say that again. More weight loss, no bone loss, because resistance training preserve the bone that weight loss would have otherwise taken with it. This is not a minor finding. This is a mandate. If you are on GLP-1 for weight loss and you are not doing resistance training, you are losing bone that you may not recover. So, what does this mean practically? Here is how I think about it with my patients. First, who's on the medication and why? Patients that have type 2 diabetes, bone protection is likely built in, and the metabolic improvement probably works in their favor. But we're still monitoring. Non-diabetic patients on GLP-1 for weight loss, I want a baseline DEXA scan before or shortly after starting. I want to know where their bone density is before we take significant weight off their frame. Second, high-risk groups get more aggressive monitoring. Post-menopausal women, patients over 65, patients with BMI over 40, who are going to lose large amount of weight rapidly. These are the patients where I'm thinking about whether additional bone protection, whether that's optimizing vitamin D, calcium, or in some cases bone-specific therapy, needs to be part of the plan. Third, resistance exercise is non-negotiable in my practice for anyone that's on GLP-1 for weight loss. This is not optional. The JAMA data is clear. Muscle mass matters. Bone load matters. You cannot outsource bone protection to a medication. And fourth, the ADA guidelines themselves note that while low-dose GLP-1 receptor agonists appear neutral to beneficial in diabetes, data are lacking for higher dosage, where weight loss may become more rapid, with potentially greater skeletal risk. We need more long-term data on the highest dose regimen in non-diabetic patients. Here is the bottom line. GLP receptor agonists are not uniformly good or bad for your bones. The effect depends on your metabolic baseline, the degree of weight loss, your age, your pre-existing bone density, and whether you are doing the work to protect your skeleton. If your doctor prescribed you a GLP-1 and has never mentioned bone health, that's a conversation worth having. A bone density scan, also known as DEXA scan, appropriate monitoring, and a clear exercise prescription should be part of the plan. This is exactly the kind of nuanced, individualized care that I built my practice around, because the answer is almost never one size fits all. If this was helpful, subscribe and hit the notification bell. I publish new videos every week breaking down the endocrinology your doctors don't always have the time to explain. I'll see you in the next one.